Hello friends, so ready for the physiology session? All right, um, we are going to have a quick discussion on physiology uh, for the FMGE exams. Now, what is the plan? Plan for today is that I'm going to cover three important systems. Look, first let me tell you a few general things. What are the general things? What systems? Okay, all right. So, what systems should be covered by an FMGE student for his or her FMGE exam? Uh, I have mentioned this before a number of times, but if you are writing down, please write it down. Before any exam, you should be well versed with these six systems: general physio, nerve muscle, CVS, RS, and kidney. So, these six systems, or rather general physio, nerve muscle, CVS, RS, kidney, and if the time allows, then we will have CNS also. So, but these are the main systems which you really require for your exam preparation. And during the course of our discussion, we will talk more about the FMGE exams in the past and what all things have been asked and what things can be asked, most likely questions which are asked in these exams. So without wasting any further time, I am looking at your okay uh, I am looking at your comments as we speak up. Questions are welcome, but please reserve your questions for the end of the session so that I will be able to answer and we'll have a good flow of this session rather than looking into the chat and intermittently breaking the session and answering those questions. So let's, with this in mind, let's start our discussion for today's topics. I'm going to intend to cover general physio today, nerve muscle, and if time allows, we will also have CVS, right? So it's going to be MCQ based discussion, but I'll cover a lot of theory also. Let's begin. The first question, I hope you can see, read the question. A model cell with three different transporters X, Y and Z is shown below. So which of the following best describes the transporter Y? Now look, these are the transporters, and therefore the first topic for today, which I want to cover quickly as an accelerate, because we are calling it an accelerate, is the transport proteins in the membrane. So you can see the three transport proteins shown here in the diagram in the membrane, these membrane transporters. First one, X, it shows sodium sent out and potassium brought back in. What do you think is this transporter? Come on, you can write down and I can see in your chat. Okay. Anybody? Okay, this is sodium potassium pump. Sodium is thrown out and potassium brought back in. So X is definitely sodium potassium pump, which is an ATPase. Okay. Second one is sodium calcium exchanger. You can see here that sodium is coming in and calcium is going out. This is sodium calcium exchanger seen in the myocardial cell. And this one, actually this one was asked as what transporter is it? Chloride is diffusing or moving through this channel. What is transporter Z? So sodium potassium pump, primary active transporter, and transport protein, it is ATPase or pump. Then sodium calcium exchanger, this is secondary active transport, counter transport found seen in the myocardial cell. And this one, chloride. Now only chloride is shown and bidirectional transport of chloride has been shown here. So what transporter is this, you think? This is a simple diffusion. This is a chloride channel, because you can see here it shows chloride in a bidirectional manner. All right, friends. So I hope all of you are there. There was some technical glitch in this, but anyways, let's continue with our discussion. Let's take the next MCQ. The hello, friends. Am I audible and visible this time? Looks like there is some technical glitch. Just if you can hear me and see me, just give a loud cheer or something which I can see, and then I can continue next MCQ. If it is audible, if I can be seen clearly and heard clearly. Yes. Okay. Good. Great. 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 So let's continue with our discussion and talk about the second MCQ. Now this glucose absorption from the GIT will need which of the following? I am looking at your answers simultaneously. So now can you answer this question? Glucose absorption from the GIT will need which of the following? And I am going to take the theory also. So what is it? Anybody try answering this? Come on. Glucose absorption from the gut. Okay, so let's have a quick review of what this question is all about. Look, glucose entry into all cells uses only one type of transporter, that is GLUT. It is a facilitated diffusion of glucose from high to low concentration. All right, and this is facilitated diffusion, and facilitated diffusion of glucose uses GLUT as the transport protein. Sorry, because of technical glitch, there is some ruffled feathers, but anyways, it will settle down now. You all also settle down. We will have a good discussion from this point onward. So, glucose transport from high to low concentration is by facilitated diffusion using the transporter GLUT. Now, you know, GLUT1 is a constitutively expressed glucose transporter. Have a quick revision on these facilitated transporters. GLUT1 constitutively expressed and ubiquitous, omnipresent, everywhere present. That's GLUT1. GLUT2 is present in pancreatic beta cell. Yes, for the insulin release, glucose has to first enter the pancreatic beta cell, and that is where GLUT2 causes transport of glucose from blood into the pancreatic beta cell. Then GLUT3, come on, can you tell me what is GLUT3? Where is it present? I am looking at your chat box. GLUT3 is predominantly present in the neurons. In the neurons, glucose entry occurs by GLUT3. And then GLUT4, insulin dependent glucose transporter. Insulin dependent glucose transporter is present at two places, two tissues. Okay, what are those two tissues? Adipose tissue and muscle. These two tissues are absolutely dependent on insulin for glucose entry. So insulin, yes, correct. People are answering now. The session is warming up now. So GLUT4 is present in the fat tissue and muscle. So these are the GLUTs. By the way, there was one MCQ, just asking a quick MCQ. Think about it, answer. Spermatozoal membrane has which GLUT? Come on, if you know this. Spermatozoal membrane has which GLUT? Anybody? Okay, anyways, the answer is GLUT5. Yes, GLUT5, because fructose is transported by GLUT5 and spermatozoa metabolizes fructose. Therefore, fructose entry into the spermatozoa utilizes GLUT5, fructose transport by GLUT5. Now, that was not the question. The question was this, that is, glucose absorption from the GIT will need which of the following? So, correct. People are answering, some answers are coming up. Let's try to see what the answer to this question is. Look, glucose absorption from the gut occurs like this. Here is the GIT, a part of the GIT, and here are the cells lining the GIT. Okay. Now, glucose in the lumen has to enter the blood vessel. This is the glucose that you have consumed. It is in the digestive lumen and it has to be absorbed into the bloodstream. That means it has to cross two membranes, as you can see in the diagram. Apical membrane facing the lumen and basolateral membrane facing the blood vessel. So glucose will have to cross these two membranes to finally enter the bloodstream, enter the blood vessel. Now the question is, what transporters are utilized by glucose? And therefore the answer is On the apical membrane, there is a secondary active transporter called as SGLT. And to be precise, in the case of GIT, it is SGLT1. SGLT1, sodium glucose transporter. And why is it needed? It is needed because glucose is entering the cell against its concentration gradient. Which cell are we talking about? The GI lining cell. So glucose is entering the cell, means going against its concentration gradient from low to high concentration. Therefore, it requires an active transporter. Okay, so that is SGLT1, secondary active co-transporter. And then from the basolateral membrane, glucose can leave the cell and enter the vessel by using which glut? Come on, tell me. You must have done this. Whenever glucose has to leave the cell, it uses only one type of transporter, and that is GLUT2. So GLUT2 will be utilized to leave this cell and enter the blood vessel. And therefore, for glucose absorption, two transporters are utilized. One, SGLT1, which is on the apical membrane, in the apical membrane, and on the basolateral side, means facing the blood vessel, there will be GLUT2. So I want you to just remember this one little fact, and that is okay, right. So the fact that I want you to remember is this, that glucose leaves the cell by using only one type of transport protein, that is GLUT2. Whenever glucose has to leave the cell, for example, there is muscle or liver glycogen. You know, glycogen is stored in the muscle or in the liver. Whenever we need glucose in the blood, this glycogen will be broken down and glucose will be formed. Okay, and this glucose will come out of the cell and will enter the blood vessel, which means it is coming out of the cell. Which transporter will be utilized? GLUT2. So I want you to remember this one fact, which will be useful for your further understanding of the subject and appearing for the exam. So what was the answer? SGLT1 and GLUT2. So that's the second MCQ. Now let's look at the next question. I am not going to the next system. We will first cover the general physio properly, at least some aspects which are always asked in the FMGE exams, and we will move from that point onward. So let's finish the general physio MCQs first. This is about the body fluid compartments. We are talking about the body fluid compartments. Compared with the intracellular fluid, extracellular fluid has what? I mean, what they are asking is, what is the difference between ICF and ECF? Sodium concentration and potassium concentration and chloride concentration and phosphate concentration. So without looking, yeah, one thing that I want to as my experience, I want to share with you. Whenever you read a topic and now you are going to solve the MCQs, you read the stem and don't jump to the options straight away. Okay, like in this case, you can read the MCQ and think of an answer by yourself and then look at the options. If without looking at options, if you have some answer in your mind and it is there in the options, then definitely you are going to be correct for that MCQ. So always keep this in mind whenever you are solving the MCQs. Never ever look at the options first. My sincere suggestion. You know, some students, they argue, they say that, sir, we can solve the MCQ by negation, that this is wrong, this is wrong, this is wrong, and therefore this is right. No, that's not the correct method, and that should be the last resort. Believe me, first always try to read the question and try to answer without looking at the options. So here they are asking ICF and ECF, and they are asking sodium ion concentration, potassium ion concentration, chloride and phosphate. And you can see here lower concentration, higher concentration, lower, higher, whatever. So it's very confusing at the on the face of it. Anyways, compared to ICF, the ECF has high sodium concentration. Let's draw it here. ICF and ECF. Now look, ECF has high sodium and ICF has low sodium. First thing. What about the potassium? Potassium is high in the ECF and low on the high in the ICF, intracellular fluid, rich in potassium. So major cation in the ECF is sodium. Major cation in the ICF, potassium. Okay, so therefore that's what they are asking. What are the various concentrations of these ions in the ECF and ICF? Chloride high in the ECF but low intracellularly. So once we are aware that we know this fact clearly, then solving of the MCQ will be a piece of cake. So let's have a look at the options. Compared with ICF, the ECF has high sodium concentration, low potassium concentration. So high, low. Then what about chloride ion concentration? Yes, ECF has high chloride. रहा हूँ। All right, looks like there was a technical glitch. There are festivities going on all around, and therefore probably that seems to be the problem with the surroundings. There is sound and music and everything going on. So can you hear me? Just if you just give me a thumbs up, I can continue. And now the class can continue. The technical glitches have been sorted out, it appears. So if anyone attending and can tell me if they can hear me or they can see me. Anybody? Okay, so I was just trying to figure out what technical problem is going on, and it looks like it has been sorted out. So we'll continue with the MCQs. Is the sound good this time? Sound is good. I hope the sound is good. Okay. And in the meanwhile, I was just going through the some of the reactions of the students. The teacher is good, teacher is bad. Someone who is calling teacher is bad has not named himself, just the some letters, and the person knows that the sir is going to take the class, and yet he is sitting in the class for a not so good teaching. Anyways, I think all of this is very funny, but let's start with our MCQs. uh, if anyone can give me a thumbs up, we can start. Okay, ECF volume 70 kg adult man would be approximately 14 liters. Yes, uh, you know the body fluid compartments. The body fluid compartments are divided like this. Total body water is 60% of the body weight, or 0.6 into body weight. या इसमें एक पहाड़ा है, एक टेबल है. तो देखो टेबल क्या है. Total body water is 60% of the body weight, or 0.6 into body weight. Out of this, 2/3 is ICF and 1/3 is ECF. So ICF will be 0.4 into body weight and ECF will be 0.2 into body weight. तो The table, the PAHADA is 0.2, 0.4 and 0.6. Okay. Now in this body fluid compartment, these body fluid compartments, the ECF is further divided as 3/4 and 1/4. Okay. So in a 70 kg adult, 60% of the 70 kg, and that is roughly 42 liters. ICF 28 liters, that is 2/3, and ECF 14 liters, that is 1/3. So the table of 14, 28 and 42, right? 14 liter volume ECF, ICF is 28 and total body water 42. 70 kgs ka 60% and that is 42 liters. That's how you remember these figures. Can you comment? If the sound is there, light is there, can you hear me? Because there was a sound problem some time back. No sound. Medicoholic is writing. Okay. Anyway, so let's continue and look at the MCQs. Right. ECF volume will be 14 liters. Body weight, which is what we said, 2/3 of the body weight is ICF, and synovial fluid is transcellular fluid. So therefore, the incorrect option was the first one. The total body fluid per unit body weight is more in infants. That's incorrect. It is less in infants, and therefore infants are more prone to diarrhea and dehydration. Okay, at least I got a thumbs up from someone that the class is audible and visible. So let me continue, and whatever MCQs we can cover today. We also have a rest day or extra day, I mean to say, where we can continue and cover more MCQs. A 60 kg man has hematocrit of 40%. His plasma volume would be approximately. So if the hematocrit is 40%, that means the remaining 60% will be the volume of plasma. Can anyone think of this MCQ and try to answer? A 60 kg man has hematocrit of 40%. The plasma volume would be approximately how much? So they have already given hematocrit 40%, and you know, in a unit quantity of blood, 40% is volume of cells and remaining 60% is the volume of plasma. So 60% is the volume of the plasma, and they have already given 60 kg man. So then you have to just calculate the 60% and you can derive the plasma volume. So it was a similar MCQ. Again, MCQ number 5 also same. Let's go on to the next because we have lost time. Let's cover up some of the lost time here. The 7th MCQ is this. Which is the fastest conducting part of the heart? Which is the fastest conducting part of the heart? That's the question. Look, whenever you find 4, 5, 6 lines, don't get worked up by that. You know, it's not always a tough question. Look at what is asked actually, and accordingly you can answer the question. So which is the fastest conducting part in the heart? That is what is asked here. Fastest conducting part in the heart is Purkinje fibers. What is the advantage of that? Look, let's just revise it. Slowest conducting part in the heart is AV node. So that because of this slowness of conduction, impulse reaches late into the ventricles. SA node generates the impulse, then impulse reaches the AV node and then reaches the ventricles. Because AV node delays the transmission of impulse, therefore impulse reaches late into the ventricles. Okay, and therefore atria excite first, they contract the pump the blood into the ventricles, and then the ventricular contraction will start. So therefore AV node, slowest conducting part in the heart. What about the fastest conducting part? Purkinje fiber is the fastest conducting part in the heart, and therefore uh, Purkinje fiber, because it is fastest, therefore what happens is all fibers in both ventricles, they are excited simultaneously. Okay, all the fibers in both ventricles are excited together because Purkinje fibers are the fastest conducting part. And because of that, what happens is both ventricles excite together, and therefore both ventricles also contract together simultaneously. I'm just trying to see whether people are still attending and trying to answer the MCQs. Okay, so fastest conducting part in the heart is the Purkinje fibers, and the advantage is all cells in both ventricles will contract simultaneously. Okay, if the Purkinje fibers situated distal to the AV junction become the pacemaker of the heart, what is the expected heart rate? Now look, each part in the heart has got its own intrinsic rhythmicity, okay, and that intrinsic rhythmicity is highest in the case of SA node, and therefore SA node is the pacemaker of the heart. SA node generates the impulses, and that is how impulses are every impulse is generated in the SA node and sent into the ventricles. So that's why SA node pacemaker, because highest rhythmicity, followed by AV node 60 times per minute, and then even AV node fails, then there is Purkinje fiber. Okay, so Purkinje fiber has got intrinsic rhythmicity of about 20 to 40 per minute, and therefore if the Purkinje fiber becomes the pacemaker, then the expected heart rate would be about 30 times per minute, 30 beats per minute. Why is that? Because that is the natural excitability of the Purkinje fiber. I hope I am still audible because there are no reactions so far from the students. Okay, anyways, I am assuming that you all are listening, and I'll continue with the class any which way. So the point is that let's say there is a classroom, and in the classroom there is class teacher, the SA node, and there are students seated in the classroom. Now SA node has got certain rhythmicity, certain speed of teaching, just as I said, class teacher. So class teacher has a speed, and students seated in the classroom have different speeds of understanding. Like AV node is seated in the classroom, bundle of his is seated in the classroom, Purkinje fibers, they have their different speeds of excitation, but when they are in the classroom, they have to follow the speed of the SA node, which is the class teacher. Okay, and therefore SA node, which has got the frequency of 80 times per minute, will generate 80 impulses, and all parts in the heart will excite at 80 times per minute, and the heart rate will be 80. But if the SA node fails, like if the class is ending and all students go back home, then they can learn by their own speeds. So for example, AV node, the student in the class, when in the classroom, it had to follow the SA nodal impulses, but now he is independent and his natural frequency is less, that is 60 per minute. Then the heart rate will be 60 per minute. Or Purkinje fiber, even less speed of understanding. So if the Purkinje fiber becomes the teacher, then again it will be even slower teaching. So that's how each part in the heart, the point was that each part in the heart has its own intrinsic rhythmicity, and therefore if one part fails, the other part becomes pacemaker, but generates less number of impulses per minute. Right. Let's look at the next MCQ. Okay. The pacemaker potential is due to. The pacemaker potential is due to. Now this is related to the SA node. So pacemaker potential Look, SA nodal action potential shows this. This is the action potential in the SA node. Each cell of SA node shows this action potential. Now, this is repolarization, which is because of the potassium exit. At the end of repolarization, potassium exit stops and next spontaneous depolarization starts in the SA node. So this is because of accumulation of potassium. First part of the pacemaker potential. The question was on pacemaker potential. So here, this part of the action potential is called as pacemaker potential. Pacemaker potential. Okay. Now this pacemaker potential means at the end of every repolarization, the membrane again begins to depolarize and reaches threshold. This is called as the pacemaker potential. The ionic basis for that is potassium exit decreases at the end of repolarization and potassium starts accumulating inside the membrane. So that is first part of the pacemaker potential. Second part is because of the influx of sodium through sodium funny current. Sodium funny current which causes further depolarization. And then reaching of threshold is because of the calcium entry through calcium T channels. So that's the ionic basis for pacemaker potential. Potassium accumulated inside the membrane followed by sodium funny current followed by calcium T, which reaches membrane reaches threshold, and then depolarization is completed by influx of calcium through calcium L channels. So that's the pacemaker potential and the currents involved in this. I think again the fluctuation has started in the technology, so we will take just one last MCQ and we will stop here, and tomorrow till the next session we will have it sorted out. So let's take just one last MCQ number 10 and then we will stop there. This is again similar. A 55-year-old man has been diagnosed with Stokes-Adams syndrome. 2 minutes after the onset of syncopal attack, which of the following is the pacemaker of the heart? SA node, AV node, Purkinje fibers and cardiac septum. So, look, a 55-year-old man diagnosed with that, this is all just to tangle you. Okay, this will just confuse you. The history given here. Main thing is, after the syncope, which part will become the pacemaker? So basically, this is the last MCQ that we will discuss. Again, the fluctuation has started, and since festivities, there is a lot of sound also, which is increasing. So tomorrow we will have more time, extra time to cover all these 60-65 MCQs which I have brought here. Okay, Stokes-Adams syndrome means what? Let's say there is complete heart block. If there is complete heart block, then what happens is no impulse from the SA node reaches the ventricle. Every impulse stops at the AV node. That is complete heart block. But there is Purkinje fiber in the ventricle, and this Purkinje fiber has got the potential to become the pacemaker. But it takes certain time to become the pacemaker. Imagine no impulse is reaching the ventricles. Ventricles have become quiescent, they have stopped. But Purkinje fiber present in the ventricles will now become pacemaker. If it does so within 30 seconds, that's good. But if it is more than 30 seconds that the Purkinje fiber becomes the pacemaker, heart had stopped for 30 seconds and blood flow to the brain had stopped for 30 seconds, and therefore there will be syncopal attack. So such an attack is called as Stokes-Adams syndrome. So that's what happens in the Stokes-Adams syndrome. And eventually Purkinje fiber becomes the pacemaker, and this Purkinje fiber will start generating the impulses. So therefore, that's the Stokes-Adams syndrome. I think we will stop here, and we will continue the session tomorrow with the better technology and better MCQs and all the other resource material with us. So I think that's all for today. See you tomorrow.